the clozapine block is clozapine adverse effects, how to prevent and manage them. So in the spirit of most of the echo clinics, the goal really with the didactics is that they are relatively short and sweet. I will do my best to make this sweet and short, but for full disclosure, I had a hard time limiting the number of adverse effects to talk about. So with
treatments, solutions to them.
And solutions to the adverse effects. So we're going to identify the most severe. So those that are identified as having a black box warning, as well as those that are most common. And by most common, I drew the threshold that those consistently reported it more than 10%, and utilize most of the information from both clinical trials and the package insert. So we're going to start with the most serious adverse effects. So these are the ones that are officially on the clozapine package inserts. And we'll move through each one looking at what we might be able to do to manage them effectively. So myocarditis, cardiomyopathy, and mitral valve incompetence is the first block. So it is considered, so it is recommended that patients who are being put on clozapine have relatively close monitoring if they do have a cardiovascular history. So the incidence of myocarditis and cardiomyopathy tends to be relatively low, less than 5%. The myocarditis is most frequent within the first 2 months of therapy, with up to 85% of reports being within that first 8 weeks. Following the first 8 weeks of therapy, cardiomyopathy is more frequent, but either of them could happen at any point in treatment with clozapine. From a prevention standpoint, there are not specific things that can be done for prevention. So screening patients that do have a cardiovascular history and monitoring closely for symptom development. So if there's shortness of breath, if patients start complaining of flu-like symptoms, palpitations, it is recommended that you consider doing a workup for myocarditis or cardiomyopathy, depending where you are in treatment. This is not dose dependent. It could happen at any particular point in therapy. So watching for those clinical symptoms, the patient will be having to come in and have their blood drawn once a week because they've started therapy. So inquiring if they are having any new symptoms where they're feeling fatigued, they have shortness of breath, they are feeling any of those palpitations. Additional laboratory monitoring can be done if there is a suspected myocarditis or cardiomyopathy. So looking at peripheral eosinophils, C-reactive protein, potentially also doing troponin. You can see some EKG changes, so you can see right displacement. You can also see changes in the ST segment if the patient is symptomatic. You may also see some changes on the echocardiogram. There may be some patients who have very few symptoms and still go on to develop this, so those are not completely exclusive. So while we can't prevent it, we're really looking for the monitoring of it. Treatment is supportive for their cardiovascular complaints. They recommend discontinuation of the clozapine. If it's identified to be myocarditis or cardiomyopathy, there is a relative discouragement of re-challenging with the clozapine. But there is a caveat that the benefit of using treatment must outweigh the risk. That may be a little bit more difficult to be able to determine if that treatment was discontinued in the first 2 weeks of therapy. So if a patient developed myocarditis in week 4 or week 5, we may not have seen the full benefit of clozapine in that patient, so that's just something to keep in mind. It does take some documentation in order to re-challenge a patient like that. So that is something we want to be mindful of, and there's a handful of other cardiovascular conditions. The second grouping in the black box warning is the orthostatic hypotension, bradycardia, and syncope. The risk is highest during the initial titration period. If there is a rapid dose escalation, the risk tends to be a little bit higher, so that may be in a patient who had discontinued therapy and we're trying to quickly get them back up to their full dose. They do have an increased risk for orthostatic hypotension. These effects tend to be transient. They likely, in most patients, will resolve over time, approximately 4 to 6 weeks to get full resolution. but not all patients develop a tolerance to this. So there may be some patients that continue to be symptomatic, symptomatically orthostatic. So just something to keep in mind. For patients that have comorbid medical conditions and medications, we do want to be mindful of this. This may be a slower titration so that the patient's cardiac status, if they are compromised, would be able to accommodate for the hypotension or from some of the bradycardia. In some case reports, there is reports that clozapine and benzodiazepine use has led to cardiorespiratory collapse. That's not completely consistent, so it's not that if you use the combination that's going to occur, but there have been a handful of reports that have been fatal when that combination is being used. So making sure that we're paying close attention to those vital signs as we're titrating a patient up on.
Sure, right. I just want to add that those sporadic reports of cardiac and respiratory complications from benzodiazepines combined with clozapine have also been reported with combination with olanzapine. So actually a lot of these complications are not unique to clozapine, and these solutions are also applicable across the spectrum of these medications.
Absolutely, that is not just alone for the clozapine. For prevention of the orthostatic hypotension and bradycardia, they do recommend dose titration. So starting at 12.5 milligrams once or twice a day and increasing by 25 to 50 milligrams a day, and only pushing that a little bit up to 100 milligrams a day adjustments if needed, if the patient can tolerate it. Avoiding those rapid dose escalations and monitoring for any symptoms, so any dizziness that they may experience. If the patient becomes symptomatic with the orthostatic hypotension or they develop the bradycardia, there's quite a few non-pharmacologic treatments that are recommended. So encouraging intake of fluids and of salt to help build up the blood volume. Avoiding abrupt positional changes, so having the patient take a little bit of time as they're going from a seated to a standing position. Consider a reduction in the clozapine dose if that's appropriate for the patient, if they could tolerate that, could help with the patient developing some tolerance and tolerability to those effects. Again, they tend to be transient in most patients. If they're not transient and we do need to treat the orthostatic hypotension, the medication options that have the most evidence to support it is the fludrocortisone at doses of 0.1 to 1 milligram a day, or dihydroergotamine. There are quite a few reports of the use of ephedrine, although that particular product tends to be a little bit more difficult to obtain at this point. The fludrocortisone is the one that tends to have the most robust support at this point. So it could be used, again, to build up that blood volume to help with the orthostatic hypotension. The last two tend to be a little bit more straightforward. Seizure risk with clozapine has been reported. It is noted to be dose responsive, so at a significantly higher risk of seizures at doses over 600 milligrams a day. In a review of over 1,400 patients, the cumulative seizure risk was estimated to be about 10% at about just under 4 years of therapy. So there are some reports in patients that have concomitant disease states or are using other substances that may lower seizure risk that increases that risk of seizures to over 10% within the first couple years. But that's only in patients who have a history of head trauma, who are routinely using other substances that lower seizure threshold, including things like alcohol, opiates, stimulants illicitly. There was one more, but I can't think of what it is right now. So the seizure risk is present. In the prior literature, they did recommend prophylactically starting therapy. That's not the recommendation at this point. Monitoring for any seizures in a patient that does not have other neurologic conditions. If there is a concern, maybe there is a history of head trauma, having an EEG and doing a neurologic evaluation is recommended because maybe in that case, we do want to start something prophylactically. If the patient does have a seizure, they are most often tonic-clonic seizures, but they could manifest as other seizure types, including absent seizures. It's most common with doses over 600 milligrams a day. So if there is a way to reduce the dose, that would be preferential. If we're unable to reduce the dose, then we can initiate treatment. The valproic acid derivatives, so like divalproic sodium, has the most robust evidence support for being used with the clozapine. But there are other agents that have been used, lamotrigine, topiramate, and gabapentin being some of them. So this could be a collaboration done with neurology to be able to treat successfully the seizures as well as continuing treatment with the clozapine. So just because the patient has a seizure doesn't mean we have to discontinue treatment. The last of the black box warnings, I'm going to spend just a little bit of time on. This is what we covered last week. So the black box warning specifically is for the risk of severe neutropenia, so the ANC counts of less than 500. So the risk is relatively low at approximately 1% or just under 1%, and the highest risk appears to be early in therapy. It may not be dose related. It could potentially happen even later in therapy, even if there hasn't been dose adjustments recently. From a prevention standpoint, the monitoring and watching for any symptoms of an infection are the two prevention strategies. From a treatment standpoint, if treatment is required, so there are the specific guidelines for when we need to alter how frequently our monitoring is. But if there are patients whose counts tend to run a little bit low, there have been reports of success in adding granulopoiesis stimulating factors, so those factors that will actually stimulate the production of the neutrophils, or the use of lithium. So lithium concentrations of anywhere from 0.4 to 1.1 have been found to assist with the development of white blood cells. So they've both been used in conjunction with clozapine to help boost those neutrophil counts. In some patients who may be not fond of or very reluctant and hesitant to do the monitoring, especially initially, utilizing things like Emla cream to provide some pain relief for the area could be beneficial. And there are some products out now that could actually do finger site testing, finger stick testing, as opposed to a full blood draw. So there might be, there are at this point a few more options for the patients who are a little bit resistant to those blood draws. So those are our most significant adverse effects. We're going to shift to the most common adverse effects. So again, these are those that are consistently reported in 10% or more of patients who are on clozapine. So the first, and these I just listed in alphabetical order by the category which they were described in the package insert, is the hypersalivation. So the hypersalivation incidence has been widely variable. So it's been estimated in as low as 13% and in as high as 80% of patients. This could cause a pretty significant quality of life and patient satisfaction impact, and it often tends to be most problematic at night. From a prevention standpoint, during the day, there are things that could be done for the patient, such as utilizing sugar-free candy or chewing sugar-free gum, that actually will allow there to be more swallowing and make the hypersalivation less obvious during the daytime. At night, there have been some recommendations to cover the pillow with a towel, or potentially prop up the head of the bed or use multiple pillows behind the head. This may assist with some of the clearing, but may not necessarily completely resolve that problem. So in patients who have more moderate to severe hypersalivation, that pillow may be saturated by the time they wake up in the morning. And that would not be the most wonderful way to start your day. So other treatment options. Dose reduction of the clozapine in some cases has been found to be beneficial, but in most cases we do look at adding other treatment options on board. So potential options, the alpha-2 adrenergic agonists, so things like clonidine and guanfacine, they have been found to be effective, although there is a concern of additive hypotension. So from a tolerability standpoint, if the patient already has a lower blood pressure, we may want to stay away from those agents. The alpha-1 antagonist, terazosin, actually has relatively robust data in improving hypersalivation by some objective rating scale measures, and it's been used in combination with antimuscarinics like benztropine to even show a more robust response in improving hypersalivation. For the antimuscarinics, the glycopyrrolate, benztropine, and trihexylphenadil have the most standardized evidence to support their use, but atropine eye drops and the ipratropium nasal spray also have some reports of efficacy. For patients, so the antimuscarinics do carry the risk of potentially exacerbating the constipation that we may see with clozapine. So the botulism toxin injections have also been found to be beneficial in patients that may not be able to tolerate or don't get efficacy from some of those other agents. The tachycardia, so we're back to the cardiovascular effects. So this is reported in up to a quarter of patients, and they may see a change of about 10 to 15 beats per minute. So the thought is that this may occur from two different sources. It could be reflex tachycardia from that hypotension, or it may be a result of the vagal inhibition with the clozapine having some anticholinergic activity. In some patients, they may develop tolerance. So in some cases, we may just want to watch this, where they will have some tachycardia, but they adjust to it over the course of 4 to 6 weeks. So in some cases, we can monitor those symptoms. Encouraging hydration, making sure we're doing a slow titration, and maybe lowering the dose of clozapine and holding it there may assist with the development of tolerance. If that's not enough and we do need to treat the tachycardia, the agents that have been used most commonly are beta blockers. So propranolol and atenolol have both been reported to have efficacy in assisting with with bringing down the heart rate. It is important in these patients that we are teaming up with either the primary care doctor or with cardiology, because there is a risk if they're having other arrhythmias that these could potentially make that worse. So we want to watch to see if they can develop some tolerance. If not, we do have some treatment options that we could use. Yeah, the last two tend to be two of the most problematic. So sedation can occur in up to half. I was actually surprised that that it wasn't reported in more than that, because this does tend to be one that the vast majority of patients do report. It happens early in therapy. Patients may develop a tolerance again over those 4 to 6 weeks. The good sleep hygiene can help with some of the sedation, potentially looking at the distribution of the medication and not giving a large dose in the morning may help with some of the daytime sedation. There are some reports of treatment with stimulants or levodopa assisting with the sedation. Other stimulant type agents are those used for narcolepsy, such as modafinil, did not demonstrate improvement in wakefulness or fatigue in patients that are on clozapine. One of the risks associated with using those agents, though, is that it could potentially exacerbate psychosis. So it does have to be done very strategically at the lowest doses possible for those patients. And the last adverse effect is constipation. So this had a pretty consistent report of about an incidence of 14% in patients, mainly attributable to the anticholinergic activity, but it may progress and lead to death from severe ileus or obstruction. So it is important that somebody's asking patients who are on clozapine if they are experiencing constipation. On the prevention side, hydration, having a balanced diet with a good amount of fiber, encouraging regular physical activity can assist with the constipation. Bulk-forming laxatives, so things like psyllium, or stool softeners like Docusate could help, but only in patients who have mild constipation, who maybe infrequently have this. If they have more regular constipation or it's not resolved, using the bulk laxative actually may lead to an obstruction. So we would be looking at things like osmotic laxatives, like the polyethylene glycol, moving to stimulant laxatives like the Senna and Bisacodyl, or potentially using enemas. Of those three, the polyethylene glycol is the one that's recommended if we do need to use something chronically. So just to wrap up, there's a lot of monitoring that we can do. This is a great opportunity with the use of clozapine to really be continually involved with assessing the side effect burden that patients have. While we can detect things early, maybe promoting a healthy lifestyle can help manage those. But if we're unable to manage them with the healthy lifestyle, we do have some treatment options that are available.